So thank you so much to the scientific committee chair of the session and AIOC for allowing us to speak on this. So I'll be speaking on endoscopic vitrectomy and how it allows us to usually obviate the troubles and the obstructions caused by an opaque media. Now, if you look at it, usually in eyes where there used to be an opaque media, our earlier approach used to be using a temporary keratoprosthesis. The problem with that is that subsequently you have to follow it up with the penetrating keratoplasty. So you need to put an optical graft subsequently. It also rules out custom corneal surgeries like keratoprosthesis immediately, and it's also got a relatively longer recovery time, and there is obviously a need for multiple procedures. Endoscopy allows us to obviate these problems and allows us to get away without using a temporary keratoprosthesis. It gives us an opportunity of a better visualization of breaks and membranes, can be diagnostic as well as therapeutic. The problem is that it comes with a bit of a learning curve, but that can usually be overcome. So let me just show you a few examples. So endoscope initially was developed in 1934, quite a long time back, but the modern day flexible endoscopes were something which were developed in 1990, followed by 23G probes in 2011. And this is how the endoscopy system usually looks like. This is the E4 system, which has got a light source, a fiber optic camera, and an endolaser unit which is built inside the endoscopy system. And so what you have over here is this fiber optic camera, which can be fixed over here with a laser probe, and which is fused with an optical fiber with 19, 23, and 25G microprobes, which are easily available now. So this is the view that we have over here. And the thing is, what we need to understand is, unlike our conventional vitrectomy system, which gives us a bird's eye view of what we are visualizing, an endoscope gives us an end-on view. So what you will be visualizing is what the endoscope focuses upon. So you'll just have an end-on view, and that is the thing that needs to take time for us to get used to, and that's where the learning curve lies. But the good part is it gives us a field of view around 50 degrees in water, around 70 degrees or more in an air-filled globe. It also allows us to visualize subretinal, and if there's a subchoroidal or subciliary placement, then those areas also are easily visualized. So this is like what I was saying, this is how the visualization is. What you see over here is that you see a surgeon operating over here, and this video is not playing. Yeah. And you need to get used to look at the screen in front of you rather than looking inside a microscope. So you need to visualize it through a screen, and that's the other learning curve and the different thing that we need to get used to. But the advantage is that it allows us to access these sites like ciliary sulcus, sclerotomy site, ciliary body, pars placata, and also obviously endoscopic endocyclophotocoagulation, which is done by a lot of our glaucoma colleagues. So I'll skip some of these slides because I believe in the next session I'm also talking on endoscopic vitrectomy in endophthalmitis. But I'll quickly show us how it helps us in a lot of these cases with also diagnostic endoscopy. So in eyes like this earlier, where we used to rely on either a B scan to visualize what's happening, endoscopy now allows us to visualize the entire disc status and the retina status, and therefore probably will help us in better prognostication in a lot of these cases. So these are images from one of our paper which we had published, where if you see this failed graft or eyes with keratoprosthesis, while an ultrasound reveals an attached retina, what we found when we did an endoscopic vitrectomy or a diagnostic endoscopy was a totally pale disc with sclerosed vessels. Again, in this eye, while a B scan shows an RD, an endoscope helps us in assessing a totally complete necrotic retina, an eye which was not amenable to further surgical interventions or a repeat keratoprosthesis. Thus, it helps us in prognosticating in these cases. So this is how, this was another eye which had a totally opaque cornea. Our cornea colleagues referred the patient to us for assessing the retina status, and we found a total optic atrophy along with scarring at the macula, and therefore then we deferred any further surgical intervention in terms of a keratoprosthesis for this eye. In terms of surgery, how do we go around measuring from the optical cylinder? We can measure from the center of the cylinder, taking a distance of around 9 millimeter. It helps us in visualizing the cannulas and their location. And if inadvertently we end up going into a subretinal space or subchoroidal, that can be prevented. This was another one of these cases where we did a diagnostic endoscopy to visualize the optic disc and the macular status. But let me show you some more areas. Assessment of ciliary body structures, peripheral membranes, again becomes easy. We were earlier talking about how anterior membranes are such a big cause of PVR, and what endoscopy also does is it allows us to visualize these. So these are some of the cases where you can easily see a PVD IUD induction can be done easily in these eyes once you get used to it. Membrane peeling, this actually is a video which I took from Dr. Rajiv Reddy. He was the one who started doing endoscopy the first time in LVPI, and the one who has actually taught most of us, me and Vivek and my other colleagues who do endoscopy right now. So another one of his cases, and this is what we were talking about. I'll just take 1 minute, thank you. So endoscopy allows us visualizing the entire peripheral retina, and this is where we were able to remove a lot of these peripheral membranes, what Dr. Talwar was saying about earlier about how anterior membranes are the ones which are more difficult to access. So these eyes, and this again was this patient who had a peripheral detachment when we went inside, and visualizing the peripheral retina, stabilizing the eye with PFCL, subsequently doing laser. All of these maneuvers can be achieved with the help of an endoscope. So in a nutshell, I'll come to these later on. Endoscope also, this was a patient, and Dr. Ritesh had a talk on foreign body removal. So this was a patient who had come with recurrent episodes of inflammation, and when we did an endoscopic visualization, what we found was that there was a foreign body which was located in the angle. So this was an occult foreign body which we were able to visualize subsequently with the help of an endoscope, and then we removed the foreign body subsequently. So in a nutshell, endoscopy allows us to overcome the challenges presented by anterior segment opacification and helps us in taking care of these eyes. Also gives us an opportunity of a very early intervention in eyes which would otherwise have been limited for either waiting for a temporal prosthesis or waiting for the media to become clear. Thank you so much.
Do you do endoscopic vitrectomy for patients who get chronic hypotony following a VR surgery?
So we are doing it now for some of our uveitic eyes and eyes which have got a chronic hypotony. It gives us a much more better way of assessing those peripheral ciliary body membranes and trying to truncate and remove them. So we have started doing them for our uveitic eyes and eyes with the persisting hypotony.
And is it possible to do it as a bimanual procedure, putting a chandelier inside?
I have not tried it, because if you are putting a chandelier, again there's a difficulty in visualization because you have got a light probe which is there along with the camera.
Yeah, so, but some of these cyclitic membranes don't come out on a unimanual basis. You need to...
So till now I've got away with you doing it unimanually, but yes.
Question, how you follow this patient in the post-operative period with the
Sir, that is actually one of the biggest challenges for these cases. You can't easily follow up these cases. That's the biggest challenge that we have. While we can do an endoscopic vitrectomy at that point of time, put oil, but the subsequent follow-up is a challenge. We can just follow them on the basis of an ultrasound and see what's happening. But the follow-up has been one of the biggest limitations.
Yeah. Thanks, Dr. Mudit. That probably explains why very few people keep speaking about endoscopic vitrectomy.
Yes.